Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bower, the editor of GP Online. Today on the podcast, I'm joined by our deputy editor, Nick Bostcock, to talk about the GP contract deal for England for 2024-25. And I'll also be talking a bit later to our senior reporter, Kimberley Hackett, about a couple of related stories she's written over the past couple of weeks. Coming up, we'll be looking at how the contract deal will affect practice finances, as well as some of the other changes it will bring. We'll also be talking about the very human impact of underfunding in general practice after we reported last week that some unemployed locum GPs are being forced to use food banks, and about a practice that is having to cut back services because of funding constraints. And we'll be looking at what happens next after the BMA launched its referendum on the deal this week, and asking whether GPs in England are heading for industrial action and what that could mean. Our good news story this week is about plans for same-day access hubs in northwest London being shelved. So there's a lot to get through today, but first up, let's start with the financial aspects of the GP contract for next year in England and what it all means for practices. So Nick, we talked about the 1.9% uplift we knew was on the table a few weeks ago on the podcast, but what do we know about the final offer? Is it that 1.9% and how have they got to that figure?
That figure of 1.9% basically hasn't changed, despite last-ditch efforts by the BMA to secure something better for general practice. And it hasn't changed despite all the warnings about the likely consequences of an uplift at this level. GPs have said it's likely to mean practice closures, a reduction in services and the staff practices can afford, and worse access to general practice. We know from a webinar on the contract that the BMA delivered this week, and from letters we've got hold of over recent weeks from the BMA to Chancellor Jeremy Hunt and to the Health and Social Care Secretary Victoria Atkins and other ministers, that negotiators have presented the government with really clear evidence on this, on these risks to general practice. And I'll come on to that a bit more later when we talk about the impact this contract could have on general practice. But to come back to the basic details, the contract the government is now planning to impose on the profession for the next financial year, for 24-25, will increase funding for general practice by £259 million. That will take total funding to just under £11.9 billion in the financial year ahead. That's actually about a 2.2% uplift compared with the total spend last year. So on the face of it, it's a bit more than the 1.9% mentioned previously. But breaking that down, part of that uplift just reflects an increase in the population. It's just about GP funding standing still compared with the rise in the population across England over the past year. And once you factor that out, the remaining uplift comes to 1.9%. So as I said, that figure hasn't actually changed from the original offer rejected by the BMA England GP committee a few weeks ago. NHS England has also given some detail of what that funding uplift will be expected to cover. And it's based on an assumption that partners, salaried GPs, other practice staff and additional roles reimbursement scheme, ARRS staff, will receive a 2% pay uplift. And as accountants have pointed out, there's a massive mismatch between that and the 10% increase in the minimum wage this year, which will have a knock-on effect on wage growth for other staff. And it's also half the current rate of inflation, which is 4%.
Just ahead of details of the contract being published by NHS England, the BMA put out quite a lot of information about the state of GP funding, including how much they said had been lost from the contract over the past few years, and the sort of uplift practices would need to see to get back to 2019 levels of funding. Can you talk through some of the things they were saying in that?
We reported a little while back on some analysis of GP funding that showed practices had seen funding drop by around £350 million in real terms in the 4 years from 2019. But a letter from the BMA GP committee to the Chancellor in mid-February, so this is while last-ditch talks on funding for next year's contract were still going on, makes the argument that the actual loss for practices over the course of the 5-year GP contract that comes to an end this March is far greater than that. The BMA letter said that GP practices have seen a real terms cut in funding of around 8.7% since 2018-19, which is the financial year before the 5-year deal started. We heard this week from the BMA that although practice funding has fallen by a far larger amount in real terms over a longer period, the BMA's main ask in contract negotiations this year was just to restore funding to that 2019 level, to get practices back to where they were at the start of the 5-year contract. So they just wanted an 8.7% uplift. Obviously, the government didn't go for that. And the BMA has said that, I mentioned £350 million drop in real terms in funding in the 4 years from 2019. But the BMA has said that £800 million has been wiped off the value of the GP contract since 2019 due to cost inflation. And what we're talking about here is the fact that costs for practices have risen really sharply in recent years. I mentioned the minimum wage just now. That went up by 10% last year, and it's set to do so again from April. GPs I've spoken to about this say they absolutely welcome that rise in the minimum wage, but that from the point of view of managing a practice, they simply need to be funded to pay it. And meanwhile, cost of living pressures have meant practices have had to increase staff pay to keep up with wages on offer from other local employers. And the cost of lighting and heating for practices has spiralled in the past couple of years. I think a BMA negotiator said the other night that utility bills had quadrupled. And double-digit inflation in recent times has meant that other costs have been sky high too for practices, and funding just simply hasn't kept up with that. So practice finances have been getting tighter and tighter all the time. The BMA said just before the contract was announced that GP Partners' earnings before tax in the 2022-23 financial year had dropped by 31% on average compared with the previous year. And we reported on polling by the BMA at the end of last year that said partners' income had dropped by 20% or more on average over the previous 12 months, so in the most recent 12 months. Numbers of GP partners are already in freefall, and these are obviously not figures that are going to persuade many more to stick around.
It's a fairly bleak picture, isn't it? What have people been saying about the impact this funding uplift is going to have on practices in a really practical term?
The BMA warned before the contract was imposed, when we were talking about the prospect of a 1.9% uplift, that if that went ahead, it would lead to a slew of practice closures. And in the BMA webinar this week, Dr. Katie Bramwell-Stainer, who's the GP committee chair for England, said that in discussions with the government and NHS England about the kind of uplift general practice needs, they presented evidence collected from GPs across the country that shows partners' income has dropped by 23.5% on average over the past year. So that's actually slightly more than the 20% they said earlier in the year, presumably to do with the final figures being collected. We've reported repeatedly in recent months about GPs being unable to find work or to find enough work. And in a bit, we'll come on to a story that shows just how devastating the impact of that shortage of work is for some doctors. But Dr. Bramwell-Stainer said when practices are already losing income at such a rapid rate, and this is before a contract that accountants say could strip another £50,000 plus from an average practice because it just won't keep up with rising costs, it's inevitable that we start to see a real rise in cases where practices can't afford staff or are having to operate with posts vacant. The BMA says thousands of GPs are struggling to find enough work. And Dr. Bramwell-Stainer said it's because practices have just run out of money. Partners are finding the take-home pay they're left with after they've paid staff wages and other costs is less than the money their employees are taking home. And she used a term we've used in the past to describe practices in that position. These are zombie practices where partners earn less than their salaried GPs. And practices in that situation, as Dr. Bramwell-Stainer said, won't last very long. They're likely to hand back their contracts sooner rather than later. The BMA says about 1,300 practices have closed in the past decade, and this contract, if it remains as it is, looks likely to drive a further load of practices to the wall. But even for practices that don't close, the tightening budgets they'll be operating within could mean they reduce services, reduce staff, and all of that will have an impact on the experience of general practice that patients have, and of course on the morale of GPs delivering the service.
We know that GP Partners, that means GP funding, will be part of the independent pay review process this year. So partners have been excluded from this for the past 5 years because of the 5-year GP contract that began in 2019 had pre-agreed uplifts for each year. So this is the DDRB, or the Doctors and Dentists Review Body, which takes evidence from the government, NHS England and the BMA, and then makes recommendations on pay uplifts for all doctors and dentists. And then after that report is published, the government in each of the 4 UK nations decides on whether or not it's going to follow those recommendations and uplift pay for each group accordingly. NHS England has said that if the government agrees to a higher uplift than what's in the contract at the minute, then obviously practices will get more. But how likely do you think that is? The Department of Health and Social Care submitted its evidence to the DDRB last week, which you've been looking at. What did that have to say?
So in terms of how likely a higher uplift in the end is, I think it is pretty likely that the DDRB will recommend something higher than the government has currently awarded. There's obviously a risk that the government won't award a higher uplift, even if the DDRB recommends it. But my sense is that because the government has actually raised the prospect itself in talks so far, in discussions about the contract up until the publication of the contract last week, my sense is that the government will award a higher increase. Whether it matches fully what the DDRB recommends, who knows? But the thing is, I think it will go up from the 1.9% that we've seen so far. Having said that, the evidence that the government's put forward to the DDRB is not quite painting the same picture the BMA might. It's basically the standard low opening bid at the start of a negotiating process. It talks about the challenging economic picture for the nation as a whole and for the NHS. It uses figures that include spending on PCNs and the additional roles reimbursement scheme and so on to make the case that spending on general practice rose in real and cash terms from 2017. But obviously other analysis, which we've just talked about, would tell you that general practice lost 8.7% in real terms over the course of the 5-year contract. The government's DDRB evidence also talks about the fact that there are a record number of doctors training to be GPs, although of course it doesn't mention that many of those who are international medical graduates are finding it difficult to find employers in the UK, or that there are currently doctors out of work because practices can't afford them, as we've just talked about. Weirdly, the evidence also cites examples of things the government is doing to support GPs, but among those examples are programmes that have actually been scrapped. Things like the fellowship schemes meant to boost retention, or the new to partnership scheme, both of which the BMA asked the government to reinstate as part of the negotiations ahead of this year's contract, but which the government decided it wouldn't reinstate. It does actually recognise that GP partners are in decline, and it even recognises that the workforce as a whole has fallen. But it blames that on more GPs working fewer hours in salaried roles without really digging into the reasons why GPs might want to reduce their working hours at the moment, which I think we can take it that listeners to the podcast will understand quite well. It also acknowledges some points around burnout for GPs, for example, so it's not entirely ignoring the pressure on general practice. But then it goes on to highlight increases in income before tax for GPs, using data that goes up to 21-22. So this is income data quite likely to be skewed to an extent by income from COVID vaccinations, for example. And again, it's relatively out of date, certainly compared to the kind of information that the BMA has from polling it's carried out right now this year. So that's the kind of thing that the BMA is going to have to be pushing back against in its evidence. And we know, as it happens, that the BMA evidence to the DDRB has also gone in the last week or so. And we're expecting that DDRB evidence will be published somewhere around the summer. So it could be July, for example. I mean, a point that the BMA made last night, in fact, is that July is just not soon enough. I mean, obviously practices right now are already feeling the pinch. They're already unable to employ GPs that they would really like to employ. July comes several months into a new contract, which is another massive real terms cut in funding. So from the point of view of the profession, that DDRB evidence and hopefully an uplift beyond the 1.9% following it can't come soon enough.
Yeah, definitely. We'll come on to look at some of the other details from the contract and what happens next in a minute. But before we do that, I think it's quite important to look at the current situation we're in and the very human impact underfunding on general practice is having. We talked on the podcast a couple of weeks ago about the struggles locum GPs were facing finding work and how a lot of that was being driven by the fact practices just simply can't afford to hire them anymore, at the same time as practices are getting funding to recruit other staff under the additional roles reimbursement scheme. Our senior reporter, Kimberley, wrote a really shocking story this week about the fact that locum GPs are being forced to use food banks. Kimberley's actually out at an event today, but I spoke to her yesterday about that story, and you can hear what she has to say here.
So a GP told me they had heard about this through their role as a BMA council member. They said that GP locum work had dried up across the country and it is even difficult to find salary jobs, and that reflects stories we've reported on in the past few months. The GP I spoke to was of the firm belief that at a time when practices are struggling financially, it makes no sense that the huge amount of money available for the additional roles reimbursement scheme, which is worth $1.4 billion in the current financial year, is not available to pay for extra GPs, practice nurses, and other essential staff that practices need. The GP called the way money has been poured into the ARRS at a time when basic funding for practices has been limited a debacle. To be clear though, the GP also said that if core funding for general practice had been increased as much as it needs to be, having additional recruitment through the ARRS would have been fine.
It's a terrible situation, isn't it? Almost defies belief. We know overall there's a massive shortage of GPs across the UK. In England, there are almost 2,000 fewer full-time equivalent fully qualified GPs than there were in 2015 when comparable records began. In fact, the fully qualified GP workforce actually fallen by 952 GPs since 2019 when the 5-year contract came into effect. So given those shortages, some people might be a bit sceptical about all of this and question whether something like this, GPs having to use food banks is really happening. But you've been looking at some of the responses we've had to your story and speaking to locum GPs about some of the challenges they're facing. What have you found out from that?
So since the article has been published, the response from GPs shows it isn't as hard to believe as you might think. One GP told me his locum work and income had halved in the last 12 months, so he can see how some locums could be turning to food banks. He also thinks it could become more prevalent in the summer when the new cohort of qualified GPs start looking for work and can't find any salaried or locum jobs. Another GP said she heard of a newly qualified GP in her area who is a single parent and is struggling to cope financially because of nursery costs and a huge financial debt built up during medical training. That GP is struggling because, like others, they have recently found themselves unable to find work. And some people might say, well, why not move to an area where there is work? But as the BMA council member pointed out, GP jobs get snapped up quickly when they are advertised, so it isn't that easy to find employment. And other GPs said that it isn't so easy to move away if you have family in the area and children who are settled in schools.
Yeah, I think that's a really important point to make, isn't it? I mean, lots of people might well think if you can't find locum work, just go and get a salary job. Although, as you mentioned there's real concern that some of those work opportunities are also drying up. But locuming's been a career choice or a career option for GPs for as long as general practice has existed, really. You mentioned, a single parent there. I mean, if you're a single parent, then you might need to have a really flexible career to fit in around childcare. And that's something that being a locum GP can provide, which you might not be able to get from a salaried job, particularly, when core GP practice hours are 8 a.m. to 6:30 p.m. I mean, one of the other things that's worth mentioning as well is, Kimberley, is that you also wrote a story at the start of the week about a practice that is rated outstanding by the CQC that has written an open letter to patients explaining that it's going to have to scale back services because of funding shortfalls. And this is obviously something that many practices are going to have to look at in the coming year, given what we know about the GP contract. What exactly did that practice tell patients?
This is a practice in Gloucestershire which told its patients that the financial strain is so severe that it can't afford to replace 4 clinical and admin staff who have left in recent months. And it won't come as a surprise, given what we've just been talking about, that the practice said it also can't afford locum GP cover. Because of this reduction in staff numbers and an increase in workload, the practice said patients could be asked to access healthcare elsewhere, including a local pharmacy, and also urged patients to self-manage minor illnesses. Patients were also told that fewer appointments will be provided and waiting times for appointments could take longer. And most importantly, the practice warned that if it didn't make these changes, it could be forced to close. The practice said it felt it was important to be honest with patients about the impact of underfunding, which is why it was writing the letter and publishing it on its website. The practice also told patients to contact the local MP if they were concerned about the changes the practice was having to make. The practice actually drafted a letter that patients could use to send to their MP if they wanted to do this, and I know a number of patients have taken up that offer. Now, this letter has gathered quite a lot of interest from other GPs, and in fact, Dr. Katie Bramall-Stainer, who is chair of the BMA GP committee, suggested that every practice should use the statement as a basis to inform patients of their own current situation, which is likely to be really similar to this.
Yeah, I think really sadly we might end up seeing more practices having to make difficult decisions about the levels of services they're able to provide to patients in the coming year. Thanks very much for that, Kimberley. We're going to take a short break here and then we'll be back to look at some of the detail of what else is in the contract for 2024-25 and what happens next, including the timelines for any possible industrial action.
Like to keep up to date with current clinical practice? The Clinical Update podcast from MIMS Learning discusses a wide range of topics: contraception, cancer, climate change, COPD and chronic kidney disease, and that's just the C's. Join us every fortnight for expert interviews and key points from MIMS Learning's CPD modules, presented by our editors. You can find us on podcast players or at mimslearning.co.uk.
So, Emma, you were going to talk through some of the other things that are actually in the contract deal for 2024-25. Are there any positives in there that will do anything to soften the blow of the funding challenges practices are going to face?
No, not really, to be honest, is the short answer to that. There are some changes and some of them will bring positives for practice, but really they are going to make very, very marginal differences. I'll run through some of them. So for the QOF, so that's the Quality and Outcome Framework. So this is the payment practices receive for reaching certain targets. 32 out of the 76 indicators that make up the framework are going to be income protected. But an awful lot of those points are the ones for disease registers, which is work that practices will obviously still be doing. And a lot of the other ones are also work that practices will have to continue to do because it's good practice. So really that makes very little difference at all. One thing that might make a bit of a difference, the quality improvement indicators that were introduced a few years ago are going to be income protected. So that means they're basically not going to happen this year. That probably is a good thing, and that will save practices a bit of work. The other QOF change is that aspiration payments will increase from 70 to 80%. So these are the payments practices receive in advance based on their expected achievement in the QOF. NHS England says increasing these payments will help with practice cash flow. And obviously, it's a good thing that practices will get more up front, but the amounts we're talking about per practice are not really going to make much of a difference in the face of some of those cost pressures you were talking about earlier, Nick. The BMA were actually arguing that practices should even potentially get 100% upfront, given that there's now 20 years of data about the QOF and achievement. So I think the BMA's view is that they could have certainly gone further on those flexibilities.
And what about around PCNs?
There are some changes in terms of PCNs. There are a few changes which NHS England says will give networks more flexibility. But again, they are quite marginal changes, really. And honestly, I don't think they will make much of a difference. The Investment and Impact Fund has been cut from 5 to 2 indicators. So the only 2 indicators that remain are the ones for health checks for people with learning disabilities and fit tests for people who are urgently referred for suspected colorectal cancer. The money saved from those scrapped indicators is going to be recycled into the capacity and access payment that networks get. So that payment will increase overall, and networks will have to jump through less hoops to get some of that money compared with what they had to do last year. All of the funding streams around leadership and management for networks will be rolled into core PCN funding. NHS England says this will give PCNs more autonomy around how they organise themselves, but in reality, it's going to make very little difference at all. And the clinical director role description's going to change with, 4 key areas they're going to be asked to focus on. And then 7 of the service specifications. So these are the things NHS England tells networks they need to focus on. They're going to be rolled into one overarching specification. The enhanced access requirements, which means networks have to provide some opening hours outside of normal practice opening hours, that's staying separate, but then everything else is rolling into one specification. That includes current requirements around health inequalities, CVD prevention, and early cancer diagnosis. Again, NHS England says this will simplify things for PCNs, but I honestly can't see them suddenly abandoning things that networks have been doing on early cancer diagnosis, for example. So really, it's hard to see how it's going to change anything in reality. Things that people might be interested in as well is the additional roles reimbursement schemes. There's some changes around that. Enhanced nurses are going to be added to that. These are apparently nurses working at Agenda for Change level 7 of above. So we're talking about specialist nurses in particular clinical areas. The limits on the number of other advanced practitioner roles that networks can employ, they're being removed. There's also some more flexibilities about funding for mental health practitioners. And PCNs will also be allowed to recruit any other direct patient care role, providing it's not a nurse or a GP, very important caveat there, if their ICB says they can. But, and this is a big but, the point to remember about the ARRS is that there's no uplift to that pot of money this year, apart from what's earmarked for that 2% pay rise you mentioned earlier, Nick. Ever since the ARRS was introduced in 2019, the money has risen every year. So it meant that every year, networks have been able to employ new staff and potentially benefit from any changes to the scheme, such as new roles being added, for example. As there's no funding rise this year, if networks are already fully staffed, then most of these new flexibilities will mean nothing to them at all. One of the other changes that's actually really bad news around all of this. So up until now, if PCN's underspent on their ARRS budget, then the ICB could decide to redistribute that money to other PCNs in their area. That obviously wasn't necessarily always an ideal scenario, but at least the money stayed in general practice and primary care. But from April, any underspends will basically be lost to PCNs altogether. No one's going to get that money basically going back to the Treasury. So that's really bad news.
There was mention of continuity in the contract as well for this year. So what does it say about that in the end?
Well, it's a very brief mention. So the contract regulations will be amended to explicitly require continuity of care being considered when practices decide the appropriate response if a patient contacts their practice. So it's nothing that's really going to be onerous on practice. I mean, surely practices should be doing that anyway. But it is something more that I suggest the direction of travel for where the contract is going in future. And Amanda Doyle, who is NHS England's Director for Primary Care and Community Services, she said that NHS England is actively looking at how to include continuity in the contract. Apparently, they are looking at the minute at how to make it easily measurable and evidenced. So I think we can expect to see more of that from 2025 onwards. We know that continuity is something the BMA would like as well, a focus on continuity in the contract. But I guess the big question is whether both sides can come to a common vision about what a contractual mechanism around continuity of care would look like. There are also some other minor contractual changes which you can find out more about on our website. We'll put a link to those in the notes for this episode.
There's also some new things in the contract about data from these new digital telephone systems that practices are now contractually required to have. What do we know about that?
Yeah, this is actually quite interesting. So last year, as part of the contracts in England, practices were told they had to have a digital telephone system. NHS England said this was all about improving access for patients, and it did provide some funding for practices to make the switch if they didn't already have digital telephony. But there's been a bit of a sting in the tail with this because the ongoing costs of these systems will have to be paid by practices. And in fact, some practices have found that the initial costs that they've had to pay have been pretty steep as well. And the BMA is really unhappy about this and warned that these new systems could leave practices facing costs that are up to 3 times higher than what they were paying before, which obviously in the current situation is really bad news. But as part of the contract for 2024-25, NHS England now wants to use some of the enhanced functionality you get from these systems to understand what's going on in practices. So from October this year, practices will be contractually required to take part in a data extraction from their phone system. So NHS England are basically extracting information from every practice's phone system on 8 different measures, which include things like call volumes, calls abandoned, missed calls, how long it takes to answer calls, that sort of thing. Now, NHS England has said that the reason it's doing this is to get some sort of sense of the scale of demand facing general practice, particularly around winter pressures. And there's been a bit of an implication that some of this data could be used as a basis for a sort of OPAL framework where it could trigger some sort of support for practices if they were overwhelmed. But obviously, the real worry for GPs and practices, and this is something the BMA is really concerned about, is that this is just more data that could be used to judge practices and their performance and as a stick to demand improvements or changes of some kind. NHS England has said this isn't the case, but I think it's certainly something that GPs are really worried about. Something else that we haven't mentioned, I think is also worth mentioning here, is that when you look at all of these contractual changes that I've just talked through, leaving aside the money, I said they were quite minor and they are, but the changes that are there are all things that really push forward NHS England's agenda and the government's agenda and do very little to address the concerns of GPs and the BMA. So, for example, that role description change for clinical directors, which I mentioned, one of the 4 things they're asking clinical directors to focus on is supporting PCNs in developing integrated neighbourhood teams. Now, that's something that's an NHS England priority. The BMA says that PCNs should be focused on stabilising and supporting practices. In fact, they would say that's the reason PCNs were set up in the first place. I mean, I'm not sure NHS England ever really saw that as the reasons why PCNs were set up, to be honest. But the BMA's argument is that that's where PCN focus should be on at the minute, given the current crisis. But that's clearly not what NHS England thinks. And also those QOF changes, we know the BMA wants QOF money moved into core funding, but given the fact NHS England has only made such minor changes really suggests that going forward, the QOF is probably here to stay. This is my personal view, but I think the QOF is probably something that the government and NHS England like because it allows them to direct practices' efforts to things that they think are important. NHS England would argue that it's waiting for the results of the consultation on incentive payments that closed this week before making any changes. But really this year they could have done more around income protection and aspiration payments. We also know that many cost-neutral proposals put forward by the BMA were just rejected by the government and NHS England in negotiations. Some of the things we know that they asked for included allowing GP supervision time to be covered by the ARRS funding. They also asked for changes around exception reporting rules for vaccinations in the QOF, which currently really disadvantage practices in deprived areas. And they also asked for practices to have the option to become limited liability partnerships. Those things really, there's not really any money that the government would need to stump up for those things. But they were all rejected by the government and NHS England. And I think that probably tells you a lot of what you need to know about where we are at the minute, really. So that's all the nitty gritty, as it were, about the contract for 2024-25. So what happens next? Nick, we mentioned that referendum last time we talked about all of this on the podcast. That got started this week on Thursday. How is that going to work and what are GPs being asked?
The referendum on the GP contract opened on the 7th of March and it runs until the 27th. And the question GPs are being asked is a really simple yes-no question. They're being asked simply whether they accept the GP contract for 2024-25 or not. And I must admit, I think I was expecting the referendum not to be this Brexit-style binary choice. For some reason, I thought it might be a broader set of questions, maybe looking at a bit more detail at various elements of the contract package. But we know the BMA has lots of other evidence around the financial situation practices are in and the kinds of pressures practices are facing at the moment from its wider polling. And this really straightforward referendum will hopefully deliver a really powerful message to the government about what practices think of the contract that's been imposed on them. We mentioned the DDRB earlier, and it looks likely that there could be further discussions over the contract and the funding behind it once the review body makes its recommendations, I mentioned possibly in the summer. And the result of the referendum will provide evidence the BMA can use in those discussions, as well as evidence potentially of the need to move on towards a ballot of the profession over industrial action.
Yeah, we've also found out a bit about the possible timeline towards industrial action if the ballot delivers a no on this year's contract, which, let's be honest, seems really likely. What do we know about the timings involved in all of this?
I think it's fair to say that, it might be Brexit style in its binary nature, but I think in terms of the closeness of the result, it's unlikely to resemble Brexit. The BMA has drawn up a timeline that suggests GPs could be balloted around September this year. And the idea in terms of the timing of that ballot is that it would give the profession a mandate for action to begin the following month. And that's around the time that a date for the next general election could be announced. So the last general election was in December 2019. And the BMA GP committee wants to make GP industrial action a possible doorstep issue for canvassers during the next general election and for action to be ongoing when that election takes place. And that's likely to be in December this year.
And do we know anything about the types of industrial action we would be looking at? I mean, this is not the same as junior doctors and consultants who can go on strike, because obviously we know that GP partners are independent contractors and they are effectively the employers of other GPs. So what types of industrial action would they be looking at?
We've known for some time that some of the options under consideration could include things like collection of undated contract resignation letters from practices. And that's something the BMA GP committee said this week had proved a powerful tool in the past. And also things like collective closure of practice lists have been on the table for some time. But as we heard from the BMA this week, action by general practice would have to be in a form very different to the kinds of action that other branches of practice might take. And that's, in part because of the direct relationship practices have with their patients, as well as you mentioned just now, that the complexity of the situation for practices as contractors, which is really different from the situation in hospitals where the doctors are all employees. The BMA GP committee said this week that it would want forms of action to really target NHS England and the government and to have an impact on them rather than on patients. I'm sure that's something that speaks to probably the biggest single concern that GPs have about the idea of taking part in industrial action, that it could affect their patients. The idea that the actions would not focus on patients or try as much as possible to limit the impact on patients is really key. They also said this week, the BMA, that action for general practice would be a marathon and not a sprint, rather than the kind of bursts of strike days that we've seen in the hospital sector. In general practice, we might see something more like a prolonged shift in the way practices do things that would be designed to affect NHS England or the government, as we've talked about. The GP committee suggested that practices could look at partial or complete list closure. They could choose to limit who or how they refer via the electronic referral service. And they could do things like refuse to engage with advice and guidance. GPs could also decide to switch off data sharing agreements, some of the things you touched on from the latest contract, or hand in their notice on all shared care agreements on the grounds that they no longer have the capacity to deliver them. They could stop rationing, effectively, stop holding risk for patients and just refer more. And then there's the prospect of a mass adoption of BMA safe working advice, for example. GP practices deliver nearly 1.4 million appointments a day. And based on safe working advice, that's not a safe level for the current workforce to deliver. So practice switch to 25 routine appointments per GP per day with longer appointments. That could have a really big impact. Taking that kind of action is the kind of thing that makes GPs worried about the impact on patients that it could have. But there's also an argument that longer appointments, more continuity, and the kind of impact that would have on the level of service that GPs are able to deliver in each consultation that they do would actually be beneficial to patients in the end. The BMA says it will also hold behind closed doors sessions with GPs across the country over the coming months. And that'll be to discuss other forms of action practices could take. So the menu of options we're looking at could well expand depending on the ideas that GPs come up with. But the GP committee is really clear ultimately that practices have the power to take action that could put huge pressure on the government and NHS England if they act together.
Well, after all that, it's a good job we have a good news story for this week. And this week, it's about same-day access hubs in northwest London. We've not really talked about this on the podcast recently, but it's a story that has had a lot of interest on our website. So this was a plan by Northwest London Integrated Care Board for primary care networks to set up same-day access hubs. These hubs were intended to stream access to same-day care and provide this at scale as part of the wider integrated urgent care system. But there was a whole host of issues with this proposal and concerns from GPs about the plans. Firstly, the ICB had suggested that these hubs would mostly be staffed by additional role staff, which could have left one GP supervising over 100 patient contacts a day. So there was a lot of concern around it just from a patient safety point of view. The plans were also really based on just moving existing staff around rather than new staff, so it wasn't necessarily going to build any capacity into the system. And there were obviously real concerns about the impact such a plan would have on things like continuity of care. The other major concern was that the ICB planned to put the requirement for these hubs into what Northwest London calls its local enhanced services single offer from this April. Basically, that ICB has bundled up all of its locally commissioned services and practices can only sign up to these as a primary care network now. It's also an all or nothing thing. You either do all of them or you do none of them. And obviously that means that PCNs and their member practices have to do all of them because they can't afford not to do them. So putting the hubs into that bundle would have effectively made them mandatory. So anyway, after a real outcry from GPs and patients, the ICB has backed down and said that the hubs won't be part of the single offer from April 2024. And instead, it has said it will work with local GPs with a view to working out how they can improve access over the coming year. So this is actually a really positive story. It's interesting that at that BMA webinar this week, Dr. Katie Bramall-Stainer highlighted this as a real example of how GPs can make changes happen if they work together and they work in partnership with patients. A lot of the pressure on the ICB about this plan did come from patient groups and from results from patient surveys as well as from local LMCs. And obviously she's hoping that an approach like that will also work on a national level when it comes to the GP contract. Well, that's it for this week. Thanks to Nick and Kimberley. Bit of an epic one this week, but thanks for listening. If you're enjoying the podcast, please do think about giving us a rating and leaving a review. And don't forget, you can subscribe to Talking General Practice wherever you get your podcasts, so you'll never miss an episode. I'll be back next week, so please join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting primary care and the latest on the GP contract on our website at GPonline.com.